In 1799, George Washington rode out on his estate at Mount Vernon on a cold December morning and came home with a sore throat. He was 67 years old, physically robust by the standards of his era, and had survived smallpox, pleurisy, dysentery, malaria, and the entire 8-year military campaign of the American Revolutionary War without once being incapacitated by illness long enough to lose a battle. A sore throat should not have been a problem. What followed over the next 24 hours is one of the most thoroughly documented medical catastrophes in American history. Washington's physicians, 3 of them, summoned in succession as his condition deteriorated, removed approximately 40% of his total blood volume through repeated bleeding. They administered calomel, a mercury compound, as a purgative. They applied blistering agents to his throat to draw the infection to the surface. George Washington died within 24 hours of his first symptom. The sore throat did not kill him, the treatment did. But underneath that specific catastrophe, underneath the bleeding and the mercury and the blistering, was a simpler, older, more universal problem that had been killing human beings since the first one picked up a sharp rock and accidentally cut themselves with it. The wound, not the dramatic wound, not the battlefield amputation or the surgical incision. The ordinary wound, the scratch, the cut, the abrasion that every human being sustains in the course of ordinary life, in every era, in every civilization, on every continent. For most of human history, that scratch was a potential death sentence. And before this story is over, you will understand how something as simple as a piece of clean cloth wrapped around a cut, something so basic that you have done it without thinking hundreds of times in your life, took humanity 4,000 years of wrong answers, mass death, and one ignored genius to finally get right. To understand what wounds meant before bandages, you have to understand what infection meant before antibiotics. A cut in the skin is not merely a physical injury. It is a breach in the single most important barrier the human body possesses against the microbial world. A world so densely populated with organisms capable of killing a human being that the only reason you are not dead already is that your skin is intact and your immune system is functional. Break the skin. Introduce bacteria. Give those bacteria a warm, nutrient-rich, oxygen-limited environment, the interior of a human wound. And what follows, without intervention, is a process of bacterial multiplication so rapid and so thorough that what began as a scratch can become a systemic infection within days. The stages are consistent and documented across every medical tradition that ever tried to describe them. Redness, swelling, heat, pus, spreading redness tracking up the limb toward the body's core. The sign, in any era, that the infection has entered the lymphatic system and is moving toward the blood. Sepsis, organ failure, death from a scratch. This was not a rare outcome in the pre-modern world. It was a common one. Historians studying mortality records from medieval and early modern European populations estimate that wound infection from injuries that today would require nothing more than a bandage and perhaps a course of antibiotics was responsible for a significant share of adult deaths across every social class, every occupation, and every season. Kings died of infected scratches. Soldiers died of minor wounds that became infected before the battle was even over. Mothers died of infected tears sustained during childbirth. Children died of infected scrapes sustained during play. The wound did not have to be dramatic to be lethal. It had to be unlucky. The oldest known medical texts in human history are wound management documents. The Edwin Smith Papyrus, an Egyptian medical text dating to approximately 1600 BC, believed to be a copy of an even older document from around 3000 BCE, is almost entirely concerned with the treatment of traumatic injuries. It describes 58 cases of wounds, fractures, and dislocations, with a clinical precision that surprised modern physicians when it was first translated in the 19th century. The Egyptians used honey on wounds. Raw, unprocessed honey applied directly to the wound surface and covered with a linen dressing. This was not superstition. This was, by the standards of what they could have known, remarkably good medicine. Honey is hygroscopic. It draws moisture out of bacterial cells, dehydrating and killing them. It produces small amounts of hydrogen peroxide through an enzymatic reaction. Its sugar content creates an osmotic environment hostile to bacterial growth. Modern clinical research has confirmed that certain honeys, Manuka honey in particular, have genuine antimicrobial properties effective against a range of wound pathogens. The Egyptians did not know why honey worked. They knew that it worked. And across 4,000 years of wound management history, that gap, Between knowing something works and understanding why it works would be the space in which most patients died. The Mesopotamians used bitumen, crude oil tar, packed into wounds. It had some antiseptic properties and formed a physical barrier over the wound surface. It also trapped anaerobic bacteria in an oxygen-free environment, creating ideal conditions for the specific organisms responsible for gas gangrene. They were sealing death inside the wound without knowing it. The Greeks advanced wound management in one critical direction and retreated in another. Hippocrates, practicing in the 5th century BCE, made two contributions to wound care that echo through the entire subsequent history of medicine. He described the importance of keeping wounds clean and dry. And he identified, with remarkable accuracy, the relationship between wound contamination and the development of fever, this systemic response that indicated infection had spread beyond the wound site. He could not explain the mechanism. Germ theory was 23 centuries away, but he observed the correlation with a clinical precision that his successors would largely ignore for the next 2,000 years. The retreat came from a different direction. Galen, the Greek physician whose influence dominated Western medicine from the 2nd century AD until the 17th, developed and promoted the theory of laudable pus. Laudable pus. The theory held that pus forming in a wound was not a sign of infection but a sign of healing, that the body was producing this material as part of its natural recovery process, and that a wound producing abundant pus was a wound healing well. He was catastrophically wrong. Pus is not a healing product. It is the visible consequence of the immune system fighting a bacterial infection, a mixture of dead white blood cells, dead bacteria, and destroyed tissue. It is the sign that infection is present, active, and winning ground. Galen had observed pus in wounds that subsequently healed, not understanding that those patients had survived despite the infection, not because of it, and concluded that the pus was causally responsible for the recovery. 14 centuries of European medicine operated on that conclusion. Surgeons deliberately provoked pus formation in wounds. They introduced foreign objects, cloth, metal probes, caustic substances into wound cavities specifically to stimulate what they believed was the healing response. They were deliberately infecting their patients with complete sincerity, with the full weight of medical authority behind them. And their patients died of it, in numbers that would have horrified them if they had understood what they were doing. The battlefield is where wound management theory met its most rigorous and most lethal testing ground. And the battlefield record, across 2,000 years of pre-modern warfare, is a document of wound infection on a scale that makes individual case histories seem almost beside the point. In the Napoleonic Wars, the same conflict that killed French soldiers through tin buttons and Russian winter, battlefield surgeons operating in field hospitals with no antiseptic, no sterile technique, and no understanding of the microbial world worked in conditions so contaminated that a wound survived on the battlefield sometimes fared worse after surgical treatment than before it. Surgeons wiped their instruments on their coats between patients. They probed wounds with unwashed fingers. They applied dressings torn from whatever fabric was available, often the same fabric that had dressed the previous patient's wound. The mortality rate from wound infection in Napoleonic field hospitals ran between 40 and 70% for major wounds. Between 4 and 7 in 10 soldiers who survived being shot or cut on the battlefield died afterward. Not from their wounds, from what their surgeons did to their wounds. Ambroise Paré, the same barber surgeon whose battlefield observations appeared in the surgery script, had discovered in the 16th century that simple, clean dressings applied without the introduction of caustic substances produced better outcomes than the elaborate wound treatments of his era. He did not know why. His successors largely ignored the finding. The finding that could have saved millions of lives was recorded, filed, and forgotten. The revolution in wound management, the moment that transformed a scratch from a potential death sentence into an inconvenience, came from the same source as the revolution in surgical survival. Lister, 1867, carbolic acid, germ theory. The understanding that wound infection was caused by specific microorganisms introduced from the environment not by miasma, not by bad air, not by the natural process of healing, made the intervention obvious once the mechanism was understood. Exclude the microorganisms, keep the wound clean, cover it with a dressing that prevents contamination without trapping infection. The modern bandage, sterile, individually wrapped, manufactured to a standard that eliminates viable microorganisms, designed to maintain a moist wound environment that promotes healing while preventing bacterial entry, is the direct descendant of that understanding. It took 4,000 years to get there. 4,000 years of honey and bitumen and laudable pus and carbolic acid and one Egyptian linen dressing that was pointing, without knowing it, in exactly the right direction from the very beginning. George Washington's physicians were not monsters. They were not negligent by the standards of their era. They applied the best wound and illness management knowledge available to them with genuine care for a patient they understood to be of extraordinary importance. They killed him anyway. Because the standards of their era were built on 2,000 years of Galen's wrong answer, on laudable puce and deliberate contamination, and the sincere, lethal conviction that what they were doing was healing. The bandage in your medicine cabinet, sterile, sealed, manufactured to a standard that Hippocrates could not have imagined, and Galen would not have believed necessary, is the accumulated answer to 4,000 years of that wrong answer. A scratch today is an inconvenience. It was not always. And the distance between those two realities is not a distance measured in technology alone. It is measured in every person who died of a wound that this piece of sterile cloth, sealed in plastic, costing less than a penny, would have saved.